Good evening, everyone. My name is Enda Guinan, and I'm the Digital Communications Manager at Sarcoma UK. You're all very welcome to the fourth in our series of Zoom chats about all matters sarcoma this July, which is Sarcoma Awareness Month. Our previous webinars on sarcoma and women's health, clinical trials and genomics are all available on YouTube, Facebook and at sarcoma.org.uk/Zoom. And we'll put any links that we mention in the chat this evening. So our topic this evening, well, diagnosis, treatment, recovery is at the end. For people living with and beyond sarcoma, probably not. So you may no longer be a patient, but you may still have to live with pain, fatigue, mobility and mental health issues. Today we're joined by our largest panel so far, and perhaps that's appropriate given the topic of living well with and beyond sarcoma. We're going to hear something about the theory and practice of living with and beyond sarcoma from the people who research the topic, who work in the field, and of course are living with it right now. So I've got a couple of bits of housekeeping just before we get to the main event. The webinar is being recorded, so we will share that on the website tomorrow. Your details won't be on the recording, by the way, unless we spotlight you if you want to talk. So some of you will have taken part in Zoom meetings and webinars before. The basic things to know are that we, the hosts and panelists, can't see you or hear you. So enjoy the anonymity. If you would like to ask a question, however, there are a couple of ways you can do that. At the bottom there, you can see there's a chat box. So you can type a question in there for the panelists and they'll see it, or you can type it in and allow everyone to see it. If you would prefer, you can also type your question in the Q&A box, which is just down there as well, and we'll see it and we can ask the panelists. We may not be able to get around to everyone's questions, but we'll try our best. If we don't get to your question, do call the support line and we'll do our best for that. Another way you can ask a question is just raise your hand. So not actually raise your hand because we can't see you, but again, there's a little button down there called raise hand. So if you press that, I'll see you and we can spotlight you. Okay, so your host this evening is my colleague Sam Hackett, and she's a sarcoma specialist nurse and a member of the Sarcoma UK support line. And in a moment, I'll hand over to Sam and she'll lead us through the webinar. But first, a brief introduction, because I want to give as much time as possible to them. Brief introduction to our esteemed panelists tonight. Our first panelist is Debbie Artis. And Debbie works in the sarcoma service at the Leeds Teaching Hospital, where she provides guided physiotherapeutic treatment at various stages of a patient's cancer journey. She's also the very worthy winner of the Tricia Mote Award from Sarcoma UK, so we're delighted to have her here tonight to talk about her work. In July 2019, our next guest, Lisa Hall, 57, shouldn't have said that, was diagnosed with a form of bone cancer known as dedifferentiated chondrosarcoma. And a few months later, she had an amputation of her left arm and shoulder following multiple recurrences. She told us a year ago, "I remember thinking to myself, at what point do I give up? My whole world was just spinning." Well, I guess we're going to find out what's happened since then. We're very grateful to Lisa for making time to join us tonight. After deciding to see a psychotherapist herself, our next guest, Jo Ham, was so impressed with the experience that she abandoned her career in marketing and decided to retrain as a counsellor, so that she could offer similar support to other people. And since then, Jo has built a practice for individuals and organisations and her peers, offering help with psychological rehabilitation and resilience. So we should have much to learn from Jo this evening. Occupational therapists have a key role to play in helping patients remain independent. They may suggest new ways of doing things, or they may recommend the use of special equipment after surgery. They can support and advise on return to different aspects of life, such as work or school, return to driving, caring responsibilities. They're also able to advise on methods to help manage symptoms such as fatigue. With so much to offer, we're extremely grateful that our next guest, Kate Scanlan, an occupational therapist at the Royal National Orthopaedic Hospital, is able to join us to give some practical advice tonight. Dr. Lesley Storey is a lecturer at the School of Social Sciences at Birmingham City University, and among her research interests are examining patient-reported outcomes for sarcoma. Her recent studies looking at impact on the psychosocial well-being of people with sarcoma and developing a sarcoma-specific PROM, patient-reported outcomes measure. So she might tell us a little bit about that tonight too. Finally, probably no stranger to most of us, Roger Wilson is here. And Sarcoma UK literally would not be here in 2021 to mark our 10th anniversary had it not been for Roger setting up the Sarcoma Trust along with his wife Sheila in the early part of the century. Since his own diagnosis of sarcoma in 1999, Roger has been a powerhouse as a patient advocate and believes that the more we can empower patients to speak out, the better we can make the landscape for all patients. So we're honoured to have Roger and all of our amazing guests this evening. So over to you, Sam.
Good evening, everyone, and it is such a great panel. I'm so excited that we've got everyone together, and I think we're just going to kick off. One of the things that we get a lot of queries with on the support line is around fatigue, and people describe that fatigue not just as being tired, but as being completely stopped in their tracks, of not being able to do exactly what they were planning to do, and absolutely feeling like they were hitting a brick wall. And one of those questions that we often get is, should they just sink into the sofa or have a day in bed, or should they sort of fight against that and do some exercise? So I'm really interested in talking to Kate initially around her experience of what she talks to with her patients around fatigue, what she tells them and the ideas. And then we might bring in Roger and Lisa to talk about their experience. So let's start with you, Kate, if that's all right. Perhaps talk to us a little bit about fatigue, how it impacts our patients, and what kind of ideas and things you do with the patients.
Yeah, of course. Thank you very much, Sam. And thank you for having me on the call. So very, very common for people living with cancer to experience fatigue. So cancer-related fatigue is very common. They say from Macmillan about 9 out of 10 people with cancer will feel fatigued at some point in their cancer journey. So if anyone on this webinar has experienced fatigue, you're not alone. And it is really tricky, I guess, if you're experiencing fatigue, because it is quite difficult for other people to understand your fatigue and what you are going through, because we can't see it, and it is difficult to explain and understand. And sometimes there's this perception that nothing can be done and I'll just carry on, it will get better. But it's really, really important to highlight it to your care team that you are experiencing fatigue, because there are some strategies that can be put in place to help support you to get you back to doing the things that you want to be able to do. So fatigue can be caused for various different reasons. It can be caused by the cancer itself, or I guess the treatment of the cancer. So whether that be surgery, so post-surgical fatigue, whether that be chemotherapy, whether it be radiotherapy, whether it be proton beam therapy. So there's lots of different reasons why fatigue may occur. So some of the symptoms which Sam highlighted was that feeling of lack of energy or lack of strength or significant fatigue that's not relieved by rest, and you may feel exhausted, washed out, generalized weakness, reduced concentration and memory, so it might be tricky to make decisions, or thinking about lots of different topics at once, it might feel overwhelming, difficulty sleeping, or sleeping but not feeling refreshed by it. And then loss of interest in activities or feeling low in mood. So they're kind of some of the symptoms of cancer-related fatigue. So yeah, very, very common. So some of the strategies that we suggest for people to try. So I guess you are your best advocate for fatigue. So highlighting to your care team what the issue is, and then really thinking about your day-to-day life. And what you're doing in that day and what's really important to you. So what do you want to spend your time and energy doing? What do you want to prioritize? So we like to talk about kind of like the 3 Ps. So prioritizing, pacing, and planning. So prioritizing, again, what's really important to you? What do you want to do in your day? And who can help you with the not so fun things like taking the bins out or something like that? Thinking about pacing, so little bit often, so doing a little bit and then having a rest. So maybe chopping up the vegetables in the morning and then coming back to it at lunchtime, doing a little bit more, and then cooking it in the evening. So spreading tasks out throughout the day, and then scheduling in your rest breaks as well. And quite often people say to me, you know, I feel so tired when friends or visitors have seen me, it's just exhausting. But that's still using your emotional and mental energy. So spacing out those visits as well. So some of the, I guess, quick tips that you can try out. So using a diary to plan your week, scheduling in your rest breaks, where possible, sitting down to do tasks. So sitting down to do part of the meal prep, sitting down in the bathroom to do your personal care, thinking about things that you can do online, so online groceries, and taking that little bit often approach. And then stop before symptoms. And then it may sound counterintuitive, but physical activity is really, really important for fatigue management. So there's quite good evidence to support that physical activity can reduce the symptoms of fatigue. And again, it's taking that little bit often approach. So things around the house and it contribute to your physical activity as well. So I guess a whole range of different things to try. There's lots of information on Macmillan about cancer-related fatigue. And then there's also an app that's free and it's endorsed by the NHS called Untire that can kind of take you through using a diary to look at your fatigue and measuring your fatigue levels. And there also gives you tips and tricks to kind of manage your fatigue as well. So that's kind of a snapshot, Sam. Sorry.
That's a great snapshot. Gosh, there's so many ideas in there to try. Roger, I wonder, over the years, I know you've had different times when you've been fatigued. I've lost you on my screen. Have you got any ideas as well that you know has really helped? Is it a lot about managing it? Do you still have problems with fatigue? Has it got better over the years?
Yes, it's come and gone. My first period of treatment back in 1999-2000, I had chemotherapy, and that I found extremely draining. And it took me probably 2 years to get over having that particular treatment. And one of the things I learned then was set yourself some targets. You know, when you wake up in the morning, don't just feel, oh, I don't feel like getting out of bed. I don't want to have breakfast. Don't go down that road. Say, my first challenge of the day is I am going to, you know, have breakfast and read the newspaper. And my second challenge of the day then is to go down to the shops and buy a loaf of bread for lunch. Have little targets, little achievables in there. And I think that I'd add to the, you know, the thing that Kate was saying, but with another P, people. Meet people. Go talk to people. If you can just stand, you know, you've put the bins out, as she mentioned, someone's passing, have a chat with them. The contacts with people, they restore you to being you. You move out of that sort of fatiguey nerk that you're in, and you live again. Now, I've had a lot of fatigue in the last 4 or 5 years, because not only have my last cancer treatment was 8 years ago, but I've had some, you know, spinal problems and disabilities, and I can't get a lot of exercise. I find walking 200 yards is probably about the limit that I can walk. But I have other tips and tricks for handling that situation and getting physical activity into my life, such as just doing simple things like walking around the garden and picking off that dead head from the rose.
That's brilliant, Roger. They're just such simple and great ideas. I was speaking to someone on the support line this morning who said he woke up yesterday and just felt like he couldn't get out of bed. He just felt so exhausted and so tired. And he said exactly the same thing to himself. I must just get myself up and get my breakfast. I've got to get up and go downstairs and have breakfast. And then he said by the time he'd done that, he ticked that box. And then he moved on to the next little job that he wanted to do. And he said just by getting himself out of bed, it suddenly made him think, yeah, okay, I can get on with the day. Otherwise, he said he would have just gone with the fatigue and probably spent most of the day in bed.
That's no
We've
good.
just had Yeah, we've just had a question I've seen that's come in that says, I'm not sure whether my fatigue is cancer related or normal fatigue. Is it important to be able to differentiate? I don't know. Do you want to answer that, Kate?
Yeah, so I guess it's thinking about what the fatigue is impacting in your daily life. So thinking about how you can manage that fatigue, whether it, yeah, I guess it's classed as normal fatigue or cancer-related fatigue. So cancer-related fatigue is about kind of directly related to the cancer itself or the treatment from it. So whether it be surgery, chemotherapy or radiotherapy, regardless of that, I guess managing the fatigue is the most important part of it and what it's stopping you from doing in your daily life. So taking on board some of the strategies to see if they work for you, and then trying different things to see how that works. And I just wanted to add on what you were saying before about the gentleman not wanting to get out of bed, and thinking about what can you do on a good day and what you can do on a bad day, and being kind to yourself. So with treatment, you will, you know, go up and down, and in daily life, things change. And so it's just being kind to yourself and realizing, okay, it's a bad day. What can I achieve usually on a bad day? And if that's just getting out of bed, that's great. And maybe on that good day, that's when you can do a little bit more in that day. And so it's really working with yourself and being true to yourself of what you can and can't do.
And one of the things that we have often on the support line as well is around sleep, and almost people are having trouble sleeping at night, either through worry or sometimes with pain, and then they feel that they're fatigued during the day because they're not sleeping at night, and they've got themselves into sort of a cycle when they might have a bit of an afternoon nap and then they don't sleep at night. And I don't know if anyone's got any good strategies or ideas around sleeping well in along with the fatigue and how that impacts each other.
Yeah, so sleep is understandably very, very closely related to fatigue management. We all need to sleep in our day, and we know that you mentioned that worrying, and we know that emotional distress is highly related to fatigue. So emotional distress can make you feel fatigued as well, using part of that energy that you have. So in terms of sleep, so thinking about when you're going to sleep, if you need to nap, try and limit it to about a 20-minute nap, and thinking about kind of where that is in the day. So, you know, if you're going to have a nap at 7 o'clock, it's probably unlikely you'll be able to fall asleep then at 10 o'clock. So, and then sleep when sleepy, so in the evening. So limit the time in bed lying awake. And if you are kind of mulling in bed, lying awake, get up, go for a little bit of walk, change the room, read your book for a bit, then go back to bed when you're feeling sleepy. So keeping your mind occupied with activities as well, and then thinking of your routine. So trying to keep the same time that you go to sleep each night, the same time that you wake up, so you've got a bit more of a routine. And then obviously limiting things like caffeine, and because that will be stimulating and keep you awake at night, and then alcohol, so try to limit those things as well.
Great, thanks for that, Kate, that's brilliant. I think we'd probably maybe move on to another subject. I've just realised it's 7:20 already. I'm going to have to be swifter, aren't I? One of the things that people ring us about, and we have had a few queries as well today, is around lymphedema. Lymphedema, I think I'm going to get Debbie, who's on, our physio, just to give us an insight into what lymphedema is, and what we can do about it when it happens, why it happens. And I wonder if you want to start by just letting us, Debbie, know kind of exactly what lymphedema is and why it happens.
Yeah, sure. Hi. So lymphedema, we still don't know why some people develop lymphedema and some people don't. Lymphedema is a buildup of tissue fluid within the tissues, and it's a failure of the mechanisms within the body by the lymph to drain that fluid away. It varies from edema. So edema is a malfunction of that mechanism, but it's a recoverable malfunction. So eventually that swelling will go, whereas lymphedema, the malfunction occurs, but because of the mechanism behind and the reasons behind the tissue fluid buildup, it's not recoverable. So lymphedema is a long-term chronic pathology that people have to self-manage and can have help in that, in self-managing. So we see it can happen after surgery, so after any sort of sarcoma resection. So because of obviously the surgical procedure, and it can cut through some of the lymph vessels. So the vessels are all over the body, and they pass, and it's a network, and they flow into nodes, and there's collections of nodes at various points around the body, in the axilla, in the neck, in the abdomen, in the groin, behind the knee, and there's different amounts of nodes around those areas. So for example, in the axilla, there's between about 15 and 30 nodes, and they vary in size as well for patients. So they can be up to sort of I think it's a baked bean. So lymphedema is that imbalance, so the build-up of the tissue fluid. So as I said, it can happen after surgery. It can happen after radiotherapy. It can happen because of the position of the sarcoma pushing on sort of structures, vessels, neurovascular structures, and the lymph. So it can happen for a variety of reasons. So when we assess lymphedema, obviously we have to try and distinguish that from edema. So it's really more than about 3 months that the swelling's there. And when lymphedema occurs, you get this kind of pitting. So you can pop your thumb into where the swelling is, and you can see that pit that you've created. Over time, that can develop and become firmer. So the skin becomes a little bit more fibrous. There's something that you can check for. I don't know whether you've heard of it. It's something called Stemmer's sign. So you can grip the skin at the second toe, and it's present when you can't grab and create a little skin fold on your second toe. It means that there's more swelling there, so you can't make the skin fold. So when we would assess for lymphedema, we would look for things of what the reason is behind it. So we'd want to make sure there wasn't an acute incident that's causing the lymphedema, and we would look at the site and maybe where the lymphedema is coming from. We would ask about pain, because normally patients wouldn't have acute pain with lymphedema. They describe a heavy feeling or a stiff feeling in their leg. It starts to feel quite tight. It can develop more as the day goes on. Often in the early stages, there is a diurnal pattern to it, so it will develop more through the day, but it will feel a lot better the next morning, and will have gone down the next morning. So it's things like that, and things like drug history. Corticosteroids can can have an impact on lymphedema as well. So it's kind of pulling all of those things together when we're assessing patients, and what sort of stage, if they're post-surgical, what stage they're at, to try and sort of, kind of pull through whether it's edema or whether it's lymphedema.
And I know from being a nurse at the Mars and myself years ago that actually people can have lymphedema fairly soon after treatment, or they can have it quite a long way after treatment, especially with radiotherapy. It's not necessarily something that you get. Sometimes if you have surgery to the groin and the lymph nodes have been cut, then the lymphedema can be fairly quick after surgery. But for radiotherapy and other treatment, it can come later and actually kind of catch people out. They're like, what's going on? Why is my left leg now bigger than my right leg? What's happening? And I think it's one of those things you want to get people to think about and think could it be, because the sooner, I don't know if this is correct fact and you guys can put me right, but the sooner that you can get to the physio and the lymphedema service, the sooner they can help you start managing it, the better.
Definitely. I mean, when I see patients in radiotherapy clinics, I will talk to them about lymphedema and what to look out for and the signs and symptoms, to just, not in a kind of scary way, but I'll direct them to your website or the lymphedema website, and we'll talk about things like skincare as well at that time, and talk about sort of keeping that leg nicely moisturised anyway as part of the radiotherapy. But I'll bring in the lymphedema talk as well. I think that if people, because what the feedback I've had, certainly when it's taken them by surprise really, and how quick then that lymphedema develops quite far down the line from surgery.
And Roger, I think you've had problems with lymphedema over the years, haven't you?
Yes, well, my first recurrence was lymph node secondaries in my left groin, and I had the inguinal and iliac nodes all completely excised, and that was in January of 2000, a long time ago. And the lymphedema was virtually instantaneous. You know, it was the next morning. I could feel and see the swelling. And the thing I've discovered over time is that doctors are hopeless at it. Absolutely useless. You need the nurses, the healthcare professionals, the occupational therapists, the physios, and in my particular case later, the prosthetist. They understand it and have a much greater ability to help you handle it. But it is one thing that you have to learn to manage yourself. You can't, do it all yourself to start with. You have to learn from the professionals that do understand, and they've got resources they can provide. I wear a Juzo stocking at night, for example, which has to be custom made because it's over the residual limb, the amputated limb. But that helps control the swelling. And I wear my prosthetic in a particular manner, which is a little unusual, because that also helps control the swelling. So it's self-management and learning to do these things and having the support of the professionals who know about it and will support you.
And can I bring Lisa? Do you mind me talking about your lymphedema?
No, that's fine. Fine, Sam.
Because I think very often, even as sort of clinicians, we often think of lymphedema being in limbs, in legs classically, or in the arm. But your lymphedema is in your breast, isn't it?
It is, yeah. Where I had the amputation, it was a 4-quarter amputation, and they also removed the lymph nodes from my chest wall. And that's actually resulted...
Lisa, I'm just going to hold on there because you are the specialist of yourself already, the technical talker. Explain to us what a 4-quarter amputation is.
4-quarter amputation is when you have your arm and shoulder
removed.
My amputation took it's from my collarbone, half my collarbone, all the way down the side of my breast. So a massive amputation, but yeah, just a byproduct of having the lymph nodes removed in the chest wall. They took those as well. I've actually ended up with one breast considerably larger than the other through lymphedema, which has been incredibly difficult with dressing, everything really. But as Roger said, you find the right support and the right help, and you can self-manage. You can alleviate the heavy feeling. I've also looked into compression garments, which, again, no end for arms and legs, but for the actual torso is sometimes difficult. But again, just asking, researching. I found a company that was bringing out something for the torso, which I trialled for them, and that was so comfortable to sleep in. It really was, and it did help with, I felt a bit lighter in the morning, more comfortable. So yeah, it's self-management, and lymphedema. It's really taking as much care as yourself. I try and concentrate on my diet. I make sure I have plenty of water. Simple things like that. Anything and everything to make a difference. And I just don't stop researching things or looking for different things that might help. Yeah.
And Lesley, I think you'd like to come in as well now.
In terms of lymphedema, yeah, this is something which came up when we were looking at patient-reported outcome measure, SAM. So this is something where we were actually asking patients to indicate what the symptoms that they're experiencing were, what the things that bothered them the most were, and lymphedema definitely was one of those things which came up quite a lot. And again, we had a number of different questionnaires that we asked people. One was, do you experience this particular issue? But also we asked people to what degree it bothered them that there was a particular that issue. So to what degree it caused them worry or upset. And so the thing with lymphedema particularly was that actually it was something which was upsetting, and particularly the fact that it was so difficult to control. It was something that perhaps they hadn't expected when they had their diagnosis initially. And also from a psychological perspective, the fact that this is something that was a constant reminder of not just the diagnosis, but also the treatment and the fact that actually it was going to be with them long term. So this is something which has definitely come up in terms of our research with patients, both at all stages throughout the cancer pathway. That this is an issue of both a physical and a psychological issue.
I think that point that the patients raised in your research, Lesley, is so important, is that they're just not being told, or not at the beginning. People don't expect it. So they're often presenting later, or they present with a worry, not knowing what it is, because nobody is talking about it enough at the beginning to look out for it. It's great that the work that the physios are doing and telling people about it, and it needs to be, we've been mentioning it in our information, and the clinical nurse specialists are talking about it a lot more. But I think lymphedema has often been forgotten about, and then it comes up because people present with it rather than looking out for it and getting sort of help at the very beginning when they see it. I think it's such an important issue. It's something that the moment the support line opened, we constantly have had calls about lymphedema and its impact. If we move on, I'm also conscious of the time. I'd like to talk about every subject for hours. I wondered if we might move on, and perhaps we could start with Lesley, and you could perhaps tell us a little bit more about the amazing research you've been doing, because it leads into so much of the stuff that we're talking about this evening.
Yeah, that's great. Thank you, Sam. So as I mentioned, we did an extensive survey in order to help us develop a patient-reported outcome measure specific for sarcoma. So we were aware that there were lots of fairly generic outcome measures which were being used, but there was nothing that was specific to sarcoma. So we did an extensive study which was funded and hosted by Sarcoma UK, for which we're incredibly grateful, and got lots of data from that, which we used to help develop the outcome measure, which we've called SAM. So which is something that we hope will become used more routinely, not just in terms of care, but also in research as well. Now, having done that and actually sort of spent a lot of time with that, we realized we had a lot of data which wasn't directly relevant to the measure, and we looked at it to see what was coming up in that data. So, for example, we had interviews and focus groups which we used to create qualitative data, and we had a number of different time points at which we collected data. And what we found was that at every single time point, this issue of fear of recurrence was raised by patients and people living with sarcoma as an issue, as a concern. So it was something which was to some degree cyclical. So it tended to peak at the times when people were having scans or regular checkups. But actually, for some people, it was there all the time, and for some people, it was actually quite disabling. So we found that this came up, across the board, and we also found that again, it was something that really bothered people. It wasn't something that they found easy to live with. So what that did was we looked at that data and we thought, well, there's obviously something here that we could look at and explore a bit more. And we went off and we did some literature searching to see whether there were any sarcoma specific research which looked at fear of recurrence, and there's very little indeed. That all of the research that's been done in this area seems to really focus on what I would call the mainstream cancers, if you like, sort of breast cancer, colorectal, etc. And what we wondered was whether whether those findings were actually translatable to the sarcoma population, or whether there was anything specific about being a sarcoma patient which actually was related to this fear of recurrence. So, you know, we know, for example, that sarcoma is a rare cancer, so you know that's going to be an issue. We know that sometimes there are delays in getting diagnosed, which also maybe sort of feed into people's concerns about the sarcoma returning. And we also know, obviously, that the age profile and the demographics of sarcoma patients is different from those from those other groups. So, given that we have, you know, by and large, a younger population, what does that mean in terms of fear of recurrence? Is that different from, you know, people who are typically maybe in their 60s or 70s when they're first diagnosed? So we looked at all of those issues and thought, well, you know, we suspect, and you know, it was kind of a bit of a hunch, and you know, this was borne out by talking to you know, our patient groups, that actually there was something which was likely to be important and specific to sarcoma. And what we thought was, well, you know, we know that there's research going on, but actually all the interventions which are being developed, any kinds of help which is being developed, is it going to be suitable? Is it going to be actually useful to this group? So what we're actually just on the brink of launching next week is a study called Reassure Me. And Lisa is one of our expert patients who's contributed to helping us develop that. And we're starting out with a survey in which we're just looking to see to what degree fear of recurrence is an issue for the sarcoma population. So that's kind of our starting point. Is it a problem? So you know we want to get that empirical data which actually supports the idea that you know whether it's a problem, whether it's not a problem. Is it a problem within particular subgroups, either socio-demographic groups or particular types of sarcoma, and get as much information and detail as we can about people's experience of fear of recurrence, what they do to help themselves cope, what they find is less helpful, anything that they're getting in terms of their care package. So that's our starting point. That starts next week, and Sarcoma UK are very helpfully publicising that for us and actually hosting it on their website. But we're not going to stop there. So, you know, depending on what we find out, depending on what information we get from that, we're looking to use that information to go further, to actually sort of see how that can be used by healthcare professionals in terms of information that they can use when dealing with patients, when dealing with concerns. So, for example, one of the things that actually came out from our expert group was that when you go for a checkup or a scan, you are probably in a heightened state of anxiety, but also not in the right state of mind to have a good conversation about it either. So actually sort of looking at issues to do with timing and so on as well. And once we've got that element of it sorted and tied down, we're looking to use all of that data to try and help develop an intervention which would be useful to patients. So again, looking at what would be useful to patients, when would it be useful? What type of intervention would be best? Is it something which is better if it's peer delivered? Is it something which is better that's delivered by a particular healthcare professional? Or is it something which is more to do with self-management? And also, depending on what we find out in terms of levels of fear, then actually that's also going to sort of influence what sort of intervention we think is going to be most useful. So down the track a little while, so we're probably looking at a year or 18 months from now, we're hoping to have a study which actually sort of trials an intervention around fear of recurrence specific to the sarcoma population. So that's the sort of research project that we've got just about to start.
That's great, Lesley. That's brilliant, and it will be. It is, and I can see on the chat there's loads of questions, and so I will encourage everybody to get going next week on getting that survey filled in for Lesley and her team, and we can get more information. I'm really keen to bring Jo Ham in at this point because I've just seen the time, and Jo, I use Jo a lot. She provides clinical supervision for us, but she also answers so many questions for me, and I'm really keen to. She's brilliant on strategies and ideas around anxiety and managing it. So I want to get some of that brain of hers into this chat before the time is up. So Jo.
Shall I go? Okay.
Go for it, Jo.
Thank you, thank you for that lovely introduction, and it's been such a pleasure working with you and with your colleagues through the years at Sarcoma UK, providing clinical supervision and bits of training, etc. So what Sam sort of suggested I could talk to you today would be about, in a nutshell, very succinctly, coming up with a strategy or maybe some ideas for managing that anxiety, which of course is completely natural and understandable. And I'm really interested to hear what Lesley says about the Reassure Me study, because I think that sounds incredibly positive as well. But one of the things I think that has already been mentioned by a lot of the speakers is that the way to help yourself through something like this is to start with some self-compassion. Now that's slightly different from self-pity. It's about looking after yourself. A lot of people have mentioned things you can do to do with self-care, and psychologically as well as physically, there are plenty of things you can do, and there are plenty of ways you can get a little bit of control over your emotions and your worries and your feelings and your fears around what you're going through. So the first thing is a bit of self-compassion, and maybe just noticing what works for you, what helps you. And Roger mentioned people are fantastic. If you've got the energy for them, they will take you out of yourself. They will help you to focus your attention out and away, perhaps from that internalizing worry. The second thing, so that the first thing is self-compassion, self-care, and what works for you. Second thing is you are still you. And I think someone mentioned this earlier. You are not the cancer. And if they didn't, then I'm mentioning it now. You are not that cancer. You are not sarcoma. You are still the core person that you have always been. You're going through this treatment, this journey, this experience, but you are still you. And it's important to keep hold of that, and to remember that you have all of your interests, your support networks, your friends, the work you've done, all of those things remain. And it's important to remember that and to remind yourself. And the third thing I want to talk to you about briefly, without taking up too much time, is ways to actually manage those feelings of anxiety. And the first thing I would say about that is just to notice when you feel it. And a lot of people have mentioned in the chat and mentioned in the talk, you know, there are specific times where maybe it's higher, and there are times when maybe it's lower. So maybe look out for those times when it's lower and think, oh, okay, well, when I do that thing, I notice that I'm not thinking about the anxiety. So that's good. So anything that helps you reduce that and forget about it for a bit is great. But on the other hand, we have to accept that there are times, maybe around a scan or after waiting for the results, when the anxiety is likely to come up more, and the fear of recurrence has been mentioned as well. Now, we can't always control we can't control what the results are going to be. We can't control necessarily what treatment we might have to have. But what we can do is we can maybe control our own responses. And it reminds me, you'll have all heard about mindfulness and using your breath. There's a famous person called John Kabat-Zinn in America, a wonderful doctor who brought mindfulness sort of to the West. And he had a beautiful phrase which says, we can't stop the waves, but we can learn to surf. And I think, you know, that's highly applicable to everyone in this situation. Lots of situations you can apply it to. But if you think of yourself not as being engulfed by the waves, but thinking, yeah, I'm going to learn to surf those waves, to go with the feelings, to notice those feelings, to look after myself as much as I can, and to use a couple of techniques. I don't know, Sam, if I've got time to teach any brief techniques now, or just to signal them and signpost them for another time, maybe.
I think you're going to have to signal them and signpost them. You yourself could have your own program, really, Jo. We have to signal them and signpost them. Okay. But could you mention one thing really quickly? Yes. Just mention worry time, because you told me about that, and I mentioned to a couple of patients.
One of the things I was going to say, Sam. So
and they rang me back and told me it worked, and I was very, I don't think that's going to work, and it did. So tell people about that.
Thank you for that. That was one of the two little techniques I was going to offer. So I'll start with that one. So allowing yourself worry, because, you know, our brain wants to solve problems. It wants to think up scenarios, and you know, there's no point brushing it under the carpet. So the best thing we can do with those worries is, as Sam said, we allocate worry time. Now, that is not going to be 3 a.m. That's not the time to allocate it. It's going to be a nice, comfortable time, maybe mid-morning, a time when your energy levels are good for you. You know, mid-morning, perhaps early morning, whatever is right for you, afternoon, but not end of the day, bedtime, sleep time, because that's the time where you want to be, you know, calming yourself down with lovely, relaxing, soothing things. So worry time is a time of day where it's okay to set aside maybe 15 minutes, maybe 10 minutes for your worry time. And you can use your phone or your diary or whatever to remind yourself to say, okay, 11 o'clock Tuesday, that's going to be my worry time. And then any other time during the week or during the day, depending on how often you want to do that, you just jot down whatever the worry is on your list of worries, wherever you put that, on your phone, on your notebook, whatever. So you make a list of your worries, you allocate your worry time, and then during that worry time, you say, right, I'm going to allow myself all the worry I can possibly. I'm going to tear my hair out. I'm going to wring my hands. I'm going to really get worked up and worry as hard as I can about these things. And what people tend to find is, yes, you can say what's the worst that can happen. You can allow yourself what's the worst that can happen, as long as you balance that with what's the best that can happen. So you're going to flip that coin, because the imagination might want to go to that worst case. Fine, let it go there. But flip it and give it the best case scenario as well. And maybe write those things down if that's helpful. And you will find, as you practice that and as you become an expert at allocating your own worry time, that you begin to take control of those concerns in a more perhaps constructive way, surfing those waves perhaps than you were before. That's the first thing. And the second one is just using your breathing to relax. And very simply, because I know we don't have a lot of time, when we lengthen our out breath, we activate our natural calming down response. So if you just focus on your breathing, when we're agitated, we tend to breathe to the throat or the chest, the high up part. When we're calm, we breathe down to the diaphragm, to the abdomen. If you just make sure that you breathe out for longer than you breathe in, you will begin to feel calm.
It's just your voice, Jo, makes me feel calm.
Well, I can do a calming down recording, a short breathing recording.
That would be fantastic, and we can put that out on. That would be brilliant. We'd really welcome that, Jo. Thank you. And I have to say, that worry time, I was a real cynic when Jo mentioned that, but and it came up on Radio 4 as well. We can send you some links to that, and people have come back and said, actually, that really works. I was not expecting it to, but people have said it really works. So, you know, maybe around that scan anxiety time, get practicing and ready for it, because it does seem to really help people. I'm just going to bring in Enda now, because I think my time is up. Was that right?
It is, sadly.
I've got so many things I want to talk about.
I know. I was just going to say this could go on twice as long because of the quality of the responses, and you know.
Can we come back next week?
Can
we come back? Yeah, we'll come back next week. We'll just keep going.
Well, actually, let's not dismiss that. I mean, the thing is, this was the first time that Sarcoma UK has used this type of communication method, I guess. And if we see, and we are seeing, that there's an appetite for it, then perhaps there's room for something like this to be a little more regular.
Yeah, and I'm seeing myself, there are some questions. I was keeping an eye on the questions, but there are still some questions that need answering. So please do ring me and Helen. We're on the support line tomorrow. So if your questions weren't answered tonight, do give us a ring. We're on the support line 10 till 3 every day. We can definitely get back to you. And I might pick some of the people's brains on this evening to answer some of those great questions that have come in that we haven't had a chance to get to. I'm so sorry for that. But wow, thank you so much, everyone. It's been fantastic. I hope it has been for me. Brilliant.
It certainly has. Thank you very much to you, Sam, and thank you to everybody on the panel. A recording of this will be available tomorrow, and it will join the other 3 that we have at sarcoma.org.uk/Zoom. We'll also push it out through the social media channels as well, of course. And anything that was mentioned, for example, Jo's recording, we'll get that out on social as well.
And we should mention Thursday, hey?
Yes.
Very briefly.
Just coming.
I'm back on a webinar on Thursday, but
Sam is back
Woohoo!
on Thursday. Do you want to tell us a little bit about Thursdays?
I will very briefly tell you about Thursday. So on Thursday, we have Sarah Prattab, who's one of the Oxford oncologists, joining us, and Helen, who's my one of my sidekicks on the support line. And we are, I did a support group in Scotland, and a member of the support group just brought this piece of information to us, which said relatives and loved ones have not been going to clinic. And some people have never been to clinic, and their patients have got their relatives been all the way through treatment. They've never met a doctor. They've never met a clinical nurse specialist in this time of COVID. They've just never been to the hospital because of what's happened. And we thought, oh, so we are doing a group, a webinar of just any questions around sarcoma, things that for carers and family members on Thursday night. Anything that you wish you'd asked, or you haven't been to clinic, or you don't quite understand, that's what we're doing on Thursday night. And any questions goes, we'll answer anything.
Great. And just on that one, it's a little bit different in that we're asking people to register. So if you go to sarcoma.org.uk/Zoom, you'll find the details. It's quick and easy, and you'll have the bonus of getting a little reminder the day before as well. That's about it. This, as I mentioned earlier on, we are marking our 10th anniversary of Sarcoma UK. So we have a full program over the year, culminating in the Glitter Bowl next March, which tickets went on sale for today. If you go to sarcoma.org.uk/10 years, you'll see the lineup of events throughout the year. Before we go, I just want to thank our superb panel once again for coming along and sharing their expertise and their experience so openly and so generously. So please, Debbie Artis, Lisa Hall, Joe Ham, Kate Scanlan, Dr. Lesley Storey and Roger Wilson, thank you very much for your time and for sharing your expertise and wearing your knowledge so lightly, if I may say. Thank you also to Sam for hosting, and thank you, all of you who attended, for coming and taking part in tonight and in the previous sessions. And thank you very much, and we're going to close it off. Have a lovely evening. Bye-bye.
Thank you, Enda.
Thanks, everyone.